Good morning. Congratulations in being up this early in the morning on the last day of our meeting. I'm going to talk for the next 50 minutes about managing pediatric CT doses. I'd like to acknowledge a few people. Marilyn Goski is the director of Imagenologia. I'm going to speak quite a bit about Imagenologia this morning. I'd like to thank John Boone for some of the slides that I'm going to show, and along with these co-conspirators, we all worked together to generate Task Group 204, which was recently posted on the web about 2 months ago. And then finally, I'm going to use some slides that Mahesh and Don Fry originally provided. So I'm going to talk a little bit about the Imagenologia campaign and how, what kind of resources it has available to help us in managing protocols for pediatrics. I want to talk a little bit about the public health concerns that we have with respect to pediatrics relative to adults. I want to talk about the shortcomings of our current dose indices in CT with respect to pediatrics. I'll talk about the effect of patient size on these indices. And that gets us to a clinical dilemma, but the good news is we now have an interim solution, and it's AAPM TG204. If you haven't seen that, that's posted on the AAPM website, and we'll talk quite a bit about that. And then I'll talk about some applications of SSDE, and we'll try and tie this all together with respect to managing pediatric CT patient doses. Well, Imagenologia really is officially called the Alliance for Radiation Safety in Pediatric Imaging, and it's simply a coalition of healthcare organizations that are dedicated to safe imaging in the pediatric arena worldwide. And the primary objective of the Alliance is simply to raise awareness and get people to modify what they're doing. The ultimate goal of the Alliance is really to accelerate the change of local practice. And why do we need to accelerate the change of local practice? Is it really a problem? Well, Greenberg published an article a few years back and stated that it takes approximately 17 years from a scientific observation to find its way into routine local practice. And we want to see if we can't compress that to some extent. So, how bad or how good are we? Well, this is a graph of some information where patients, ED physicians, and radiologists were asked the question, what's the dose of a CT exam relative to a plain film chest exam? And they were given the choices of the doses approximately equal. The dose of CT is 10 times greater, 100 times greater, 100 to 250 or 500, of course, which is the right answer? Well, of course, here's the right answer, and we see that none of the patients knew the correct answer. That's okay, but the ED physicians outscored the radiologists in knowing the answer. And so the dose of CT was underestimated by 75% of the MDs. This isn't a SAMS course, but, I asked this question, which of the following provides a reasonable estimate of a child's CT dose? CTDIvol, DLP, effective dose, values in the DICOM structured report. Which one's the right answer? Well, none of them. You might say, well, what's wrong with effective dose? Well, we're not supposed to use an effective dose for an individual patient. The more interesting thing about this is if I put this question on the ABR exam for the residents, I wouldn't be surprised if they selected E in this situation. So we have some work to do. The founding organizations of the Alliance were the Society for Pediatric Radiology and the American College of Radiology, and of course they represent the physicians. The American Society of Radiologic Technologists represents the techs, and of course the American Association of Physicists in Medicine. The Alliance believes really in a triad. You get your best results if your radiologists, technologists, and your medical physicists are working together as a team to solve problems. So Image Gently is an education, awareness, and advocacy campaign simply to improve radiation protection for children. Today there are approximately 58 healthcare organizations that have joined as affiliate members, and we believe that those affiliate members represent about 800,000 people working in the medical industry. It's a great group to have behind you when you start talking to vendors. They realize they need to listen. So the objective is to decrease radiation dose in children. It's always a positive message. This type of message you would never see from Image Gently. Resulting dose to population will lead to higher cancer rates, accounting for as many as 2% of all cancers in the U.S. Now, there was a nice presentation yesterday about the problems with treating cancer estimates and risk from the Beer 7 report as fact as opposed to simply projections. But at any rate, you wouldn't see this from Image Gently because it's negative. And so we're trying to increase awareness through education, advocacy, and changing practice. And currently there's campaigns in CT, CR, IR, fluoroscopy, and nuclear medicine. This is what the Image Gently website looks like. If you haven't been there, and all you have to do is type in imagegently.org after www. One of the things that was originally on the website was these tables along with a protocol to help people get started in reducing doses for children in CT. And essentially this is what the table looks like on the website. You fill in all the colored squares with the required information, and this is what happens to the table, and you essentially get a reduced MAS value that's recommended as a function of either the patient's age or size. What were the goals of this? Well, the idea is that the medical physicist is going to come into the facility, measure the CTDIvol. We need to make sure that the adult doses that the facility is using are reasonable, need to be less than 25 milligray for the body, 75 milligray for the head. And the idea of the protocol then is if you follow it after you put in the MAS that's associated with the body adult technique, you will be assured that your pediatric patient doses are a little bit less than the adult doses given by that facility. Now, today that's conservatively high. There's a lot of dedicated pediatric institutions that are doing better than that. But again, we're trying to capture the low-hanging fruit. Whether we like it or not, we believe that 80% of all children in the U.S. are imaged in departments that do children occasionally, as opposed to their focused operation. So this protocol was really designed for the adult institutions. In August of 2008, Image Gently had a vendor summit. We brought the vendors together with a number of users, and it was one of the first times that we started hammering on the idea that CTDIvol is not an indication of patient dose. And pediatric radiologists and technologists have been asking for a better estimate of CT dose for kids for the past 10 years. And the other focus of that summit was to provide better training from the vendors on their equipment to allow the end user to better leverage the abilities of the CT scanner for imaging children. As a result of that, there's 8 modules on the Image Gently website, from two each from the 4 major CT manufacturers, to start to help with how do you utilize their machines more proficiently on children. The reason, obviously, that we talked about training at that summit is that my effectiveness as a trainer, or your effectiveness of a trainer, is in part tied to our understanding of our trainees. And obviously each trainee is going to have a bit different perspective, and especially in pediatrics, the needs are different. And I illustrate that by let's assume you're going to sell your home This is your house, as seen by you. In the process of selling your home, who would view your house this way? Well, obviously your lender. Who would view your house this way? All the same house now, of course. Well, this would be your buyer. Your house would be viewed this way by your appraiser. And finally, who would view your house this way? Your tax assessor. Okay? So everybody has a different perspective, and we need to be cognizant of that when we do training. I'm sure you're all familiar with the data that's been reported in NCRP report number 160. This is the data that's usually talked about, and the fact that the per capita dose that's given to the populace because of diagnostic procedures has grown dramatically in the last 20 years, but in some respects I think this is the more important point. The majority of the exams that we do on any given day are plain radiography, and the more complex exams are the minority, but if we look at the effective dose contribution from the minority of the exams, they're the biggest contributors to the overall patient dose. And as a result of that, if you look at this, 17% of all the exams done in a hospital on a given day deliver 81% of the total effective dose. And obviously the opposite is true. That means that 83% of the exams are only going to deliver about 20% of the dose. So where should we as medical physicists be concentrating our time? Well, of course, on the minority of exams that deliver the most dose. And then there was a paper that was published that suggested that 91% of pediatric doses in the ED come from CT. Let's just look a little bit at that 85% bucket of exams, and if we look at this table, we notice, as we'd expect, that 31% of all exams are the chest, which represents 3.5% of the dose. Mammography represents 9% of all the exams and 1.2% of the dose, and we certainly pay a lot more attention to mammography because of MQSA today, probably, than we're still paying attention to CT or nuclear medicine or interventional cardiac procedures. And then, of course, dental is 31% of the total exams, and again, that's down at 1.2%. This is a slide that was put together by Eric Hall a number of years ago, and it talks about the fact that children are more sensitive to ionizing radiation than adults. And we see the average here in the slide for the female and the male. It's approximately 5% over the whole lifetime. In the first decade of life, the risk is elevated to approximately 13 and 16% for children. And, of course, by the time you get to middle age, you're down around 2 to 3%. It's about the only thing that, at this point in my life, that I can do better than my children can. And so, in summary, we believe children are 3 to 5 times more sensitive to radiation exposure than their parents. And this is that same type of data just represented in a table. The somatic risk is 14.5% for children between the age of 0 to 9. So let's talk a little bit about dose. There's been a lot of talks this week about dose. In the real world, our CT dose is in the Z direction is a Gaussian-shaped profile. We have tails. We have a peak dose. As a result of that, we can define what we call the CTDI, which is of course, the integral under this profile, and we characterize it by the full width at half maximum, and of course that's equal to the product of n times t, where n is the number of detectors in the Z direction and t is their width. As physicists, we go into facilities carrying our CTDI Phantoms made out of PMMA, either 16 or 32 centimeters in diameter. We put pencil ionization chambers in the various holes of these phantoms, and of course we make measurements, and we plug the holes that the chamber is not in. For those of you that have never done any of these measurements, this is what the CTDI phantom actually looks like. The smaller 16 centimeter phantom represents the head, and of course it would go in the cavity of the 32 centimeter phantom shown here, which represents the body. This is just a picture of the 100 millimeter pencil chamber that's typically used, and then of course we know that we take the surface and the central measurement of this procedure, and we use this weighting factor as shown here to calculate CTDIvol. So what does CTDIvol tell us? Well, it tells us if we measure it correctly, how the output of the machine varies as a function of the kV, the MA, the rotation time, and the bow tie filter. So as an experiment, I took 3 phantoms. There's also a 10 centimeter phantom that is similar to the 16 and 32. It's not an official CTDI phantom, but if you have these 3, you've encompassed the entire size of the pediatric arena. And what I did was I scanned all 3 of them, but I altered the procedure. Clinically, you would pick the field of view that was appropriate for the phantom size, and in this case I didn't do that. I used the large field of view for all 3 because I wanted to keep the bow tie filter fixed. And in doing this, here's the values that were obtained for 200 mass, 120 kV, and on the 10 centimeter, 16, and 32 centimeter phantom. And of course we can use the little formula I showed you for CTDIvol, and we see that the CTDIvol diminishes as a function of phantom size for exactly the same technique. And I want to just underscore that this is a measured CTDIvol. It's not the displayed CTDIvol on the CT scanner, and there's a difference between the two. But you notice that the ratio of 47 to 18 is a factor of 2.6. So the measured CTDIvol increases 2.6 times as the phantom size decreases if my technique stays the same. I'm using the phantoms here to model the different sizes of patients, and so obviously as my patient's getting smaller, the actual CTDIvol parameter measured this way is actually going to get larger. But my displayed CTDIvol on the scanner is defined as the dose to either a 16 or 32 centimeter phantom. And as a result of that, the displayed CTDIvol does reflect changes in the output of the machine. That's why CTDIvol was originally developed. And it allows us to note the difference in dose as a function of kV, tube current, rotation time, the bow tie filter, pitch, and the source to detector distance. That's what it was designed to do. And it's really just a standardized method that allows us to estimate the radiation output between 2 different scanners. Now you're aware of the fact that a number of our colleagues have been working over the last few years, and as a result of that, TG111 was published, and TG111 addresses the shortcomings of the CTDI dose measurement protocol in that it doesn't capture all the dose tails that are associated with our multi-detector, relatively wide fan beam CT scanners today. But I'm not going to say anything more about that. That's beyond the scope of this presentation. And then the next year or so, as the phantoms get agreed upon, we will have protocols to use to correct for these fantail also. So this morning, if you don't take anything else away from this lecture, if you weren't aware of this already, The displayed CTDIvol does not represent patient dose. It represents the ability of a CT scanner to produce ionizing radiation. Well, of course, we have another dose index that's provided by the CT scanner. It's DLP. It's simply defined as the product of CTDIvol and the scan length. The unit is milligray centimeter. We can estimate the scan length by multiplying the reconstructed slice width times the number of slices. It represents the energy that's transferred to the patient. And of course, because CTDIvol doesn't represent a patient dose, neither does DLP. But we can use it to say something about risk. If we give a patient 10 slices of CT radiation and we have a CTDIvol of 20 milligray, we're going to have a DLP of 200 milligray centimeter. If I double the number of slices, my CTDIvol is still 20 milligray, but my DLP is going to be 400 milligray centimeters. So it does give us a representation of how we change technique and how that might affect the biological risk. So, in my previous example, my radiation doses were equal, but the second patient's at a greater risk because of the larger length of body that was scanned. And while DLP is the dose to a standard phantom, that can be used to indicate an increase in dose to the patient as a function of parameter changes. Now, what about the fact that when we're dealing with pediatrics, we're dealing with a large variation in size of patient? How large a variation is that really? Well, if you're working in an adult institution, you have too much experience already with large patients and obese patients. The neonate can be as small as 4 to 5 centimeters in diameter. And of course, the neonate's going to be barrel-chested, so they're round. They don't have an ellipsoid shape. I've drawn it here in this diagram as 6 centimeters. 7-month to 7.5-month neonate is going to be about 6 centimeters in size. Of course, in CT, we have a relatively heavy filtered beam, and so our half value layer at 120 kVp is going to be about 4 centimeters, and our effective energy being delivered to our patients is going to be about 70 keV. How do we manage the various sizes of pediatric patients? Well, you might say, well, the logical thing is let's deal with their age. Well, this is some data that was published in 2010 in the journal in AJR, and basically what we did here is we looked at 1,500 CT patients and we carefully measured the AP and the lateral dimensions of those patients on their axial scans, and this is the plot for the abdomen. And the point I want to make here is if I draw this horizontal red line, it of course represents the smallest adult and the largest 2 to 3 year old. Okay? So what I'm saying here is that there's 2 to 3 year olds out there in the world that are just as large as the smallest teenagers that we see that are almost 18. And so we need to use the size of the patient, not the age, to model the various sizes of patients that come through the door in the pediatric facility. Some people use weight. Weight's a better moniker than age. However, obviously I can have a tall, thin patient or a relatively short, stout patient, and weight is not going to delineate between those two. Today we have anthropomorphic CT phantoms that certainly are much better models of what's going on in the pediatric world than the CTDIvol phantom. The phantom there in the center represents a 1-year-old thorax. You see the lung field there in the spine, and the phantom on the right is the adult. and of course the PMMA phantom on the left is the CTDI phantom. These are some similar phantoms that have been developed to represent the abdomen. And again, you have a 1-year-old and an adult-sized patient there. Let's go back to that experiment that I did, where I carefully measured the CTDIvol, and the results are listed here. How does the measured CTDIvol compare to the displayed CTDIvol on the CT scanner? Well, I'm either, in this example, going to get the CTDIvol expressed based on the 16-centimeter phantom or the 32-centimeter phantom. And because CTDIvol is defined for a certain size phantom, again, the displayed value is going to be totally independent of the actual patient size that's being imaged. So the displayed CTDIvol assumes either a 16 or 32 centimeter phantom. If it's the 16 centimeter phantom, the adult dose will be over, while the pediatric dose will be underestimated. If it's the 32 centimeter CTDI phantom, the adult and the pediatric dose will be underestimated, and it can be by as great as a factor of 2.5. And of course, what's being propagated and stored in the DICOM structured report? The CTDIvol. And of course, it really doesn't represent at all what's going on with dose in the pediatric world. It's not a horrible representation in kids, but it's not a good representation, or it's not a good representation in kids. It's not too bad in adults. So as a result of that, we have a solution. It's TG204. This is the title page. It's important to note that the report was endorsed by the ICRU and also Imagenologia as it was being developed. There's a number of things the report doesn't do. It doesn't address correction factors for heads. That's coming later. Doesn't correct for the small, less than 1% doses from the scan projection image or the SCOUT. It doesn't correct for the small variation between the thorax and the abdomen, but I'll show you some data there that quantifies that difference. And it doesn't correct for the small variation in pre- and post-contrast scans. The dose delivered to the patient will be different with contrast media injected as opposed to no contrast media. And of course, the other thing that TG204 doesn't address is it doesn't address the dose tail issue, where today with CTDIvol we're underestimating the actual dose we're delivering to the patient because we're not capturing all the dose tails because our chamber's not long enough, and neither is our phantoms. So what did TG204 do? Well, it went out and it noted that there were 4 different groups studying patient size correction factors. The upper left, Cynthia McCullough and her crew were doing things with anthropomorphic phantoms. Tom Toth and I looked at a number of scanners with the standard PMMA 3-size CTDI phantoms. John Boone did work in his laboratory with Monte Carlo simulations, and of course Mike McNick-Gray and his crew have been doing a lot of Monte Carlo work. And so we took all that data from the 4 different groups and normalized it, and lo and behold, to our shock, we could fit a curve to it with a pretty reasonable R-squared value of 0.94. So this fundamental curve for the 32 centimeter phantom is the basis for all the correction factors in TG204. This is at 120 kVp for 32 centimeters. This is the same data for the 16 centimeter phantom. And as you'd expect, the correction factors are not as large for the 16 centimeter phantom as they are for the 32, and we're multiplying by fractions that are smaller than 1 for the larger patients if we're basing our CTDIvol on the 16 centimeter phantom. So you ask the question, well, that's great, Keith. What about 80, 100, and 140 kVp? Well, this curve is that original curve that I showed you, And the other curve on this slide is 80, 100, and 140 kVp data that 2 of the 4 groups had collected. And the largest error between the 2 curves is 5%. And if we limit it to 1 year and above, the difference is only 3%. So the good news is we can use these correction factors for any KV that we choose. What about scans performed in the thorax as opposed to the abdomen and the pelvis? Obviously, we've got lung tissue in the thorax. How big a difference does that create? Well, this curve is some data that has been published by Huda and others, and again, this is the original curve of TG204, and we have a 16% difference for a 12-centimeter patient. We're suggesting that these correction factors are accurate to within 20%, and so certainly these errors fall within that range. You noticed on the slides that we talked about an effective diameter on the abscissa. What is that really all about? Well, we can take the ellipsoid patient and represent that patient by a circle with an effective diameter based upon the AP and the lateral dimension of the actual patient. Here's some fitted data where that was done, and all of this is in TG204. And if we compare the AP dimension to the effective diameter, the curve is concave down and it's concave up for the lateral dimension. What if I'm doing a retrospective dose analysis and all I know about the patient is their age? I don't know their physical size. Well, here's some data from ICRU report that gives you the effective diameter of the patient as a function of their age. And so there's a table in the report that allows you to get the effective diameter from age, and from that you can come up with a correction factor. How do we determine patient size? Well, there's a number of ways we can do that. We can simply measure the lateral dimension with a good old-fashioned set of mechanical calipers that you can still find in most radiology departments. And it's not that obtrusive to the patient. Or, if you choose, you can measure the dimension of the patient on the projection scan, as illustrated in this image. Or you can measure both dimensions on the axial scan, as shown here. For all of these, if you're measuring on the axial scan or the projection scan, obviously you need to make sure the patient's centered in the gantry, because if they're not, you're going to have some magnification error that you're dealing with. So, one big precaution is to use the correction factors in TG204. You've got to know what CTDIvol phantom the manufacturer used to estimate the CTDIvol. Or you're going to have an error of as much as 100%. Now, unfortunately, there's no standard that exists today. You cannot say that all manufacturers use the 32-centimeter phantom to represent the abdomen. They don't. It's split 2 and 2. And so you need to speak to your manufacturer through your service rep if you do not know, to find out exactly when your scanner manufacturer switches from one phantom to the other. This is just an example of some of the tables in the report. This is for 32 centimeters. This is the same data for the 16 centimeter CTDI phantom. I've already mentioned that, well, what do we call this dose that we're estimating? We call it SSDE. It stands for Size Specific Dose Estimate. We believe it's accurate to 20%. It is an estimate. And as a result of that, results need to be reported with a reasonable number of significant digits. We're recommending that if the SSDE is greater than 5 milligrade, that only a whole number integer is presented, and if it's less than 5 milligrade, 1 decimal place is probably appropriate. TG204 also has a recommendation as shown here for dose reporting by radiologists. As you know, doses have to be reported today in California. Most people today are reporting CTDIvol because that's what they have. If you read this statement carefully, where everything that's highlighted, the dictator, while they're interpreting the images, needs to make a choice. But if you make a choice and specify all those things, 5 years later you can look at the patient's medical record and understand exactly what the dose number that's put in the line for milligray actually represents. It's the SSDE, and the assumptions that were made in coming to it are listed. What about a couple just sample calculations? We can measure the dimension of the patient on the pre-scan projection scan, and in this case it's 16.8 centimeters. In this case, the scanner tells us that it used the 16 centimeter CTDI phantom, and it tells us at the end of the case that the CTDIvol was 9.29 milligray. Well, we go to the report, we find the appropriate table. You'll notice here that this is for the lateral dimension, and we come down in the table to 17 centimeters, and we see that the correction factor is 1.08. We multiply that times the CTDIvol, and we have an SSDE estimate of 10 milligray. If we have the axial scan, we can measure both the AP and the lateral dimension. This time, let's assume the 32 centimeter phantom was used by the scanner, and the displayed CTDIvol was 5.4 milligray. Here's the appropriate table. It's the lateral and the AP dimension summed. We come down to 22, and we have a correction factor of 2.5, and the SSDE is 13 milligray. Let's take that same patient, and let's just assume that the scanner used the 16 centimeter phantom instead of the 32, and now the displayed CTDIvol will be 10.8. We come to a different table in the report. Again, we come down to 22, and the correction factor is 1.24. And again, we get 13 milligray for the SSDE. We get the same answer for the same patient. That's somewhat comforting. So here's a real-life situation. A child was imaged in a department on a GE CT scanner on Tuesday, and there was a need to rescan the patient on Wednesday, and they were imaged on a Siemens scanner in the same department. Well, the GE scanner displayed the CTDIvol based upon the 16 centimeter phantom as 10.8 milligray, and the Siemens displayed the CTDIvol based on the 32 centimeter, and that's 5.4 milligray. The parents got the CTDIvol data because that's all that was typically available in the department, and they weren't happy campers. They couldn't understand why their child couldn't have been scanned both days and received a dose of 5.4 milligray. And of course, that's not the patient dose. When an SSD analysis was done at the site, 13 milligray was delivered from both studies. And so the SSDE, of course, is a much better estimate of patient dose. As I mentioned before, there'll be correction factors for heads in the future because heads are based upon the 16 centimeter CTDI phantom. The correction factor will not be as large as those that we find for the abdomen. It's important, if we're going to start applying the SSDE, that we understand the differences between it and CTDIvol. SSDE can be used as a first approximation. Now notice I said first approximation of the average organ dose to the organs completely contained in a scan volume. If I irradiate the abdomen, because the liver as an organ is relatively large and it covers a large cross-sectional area of the axial scan, the SSDE is not going to be a horrible first approximation of the organ dose to the liver. Now, if I've got a small organ located somewhere in the abdomen, the approximation is not going to be as good because we know that the actual dose in the abdomen is changing as we move from the surface to the central region of the patient by a factor of 2 if it's an adult. So the SSDE can be used as the first approximation for organ doses if we're talking about relatively large organs. Obviously, we're totally out of luck if the organ is not completely contained within the scan volume. I'm never ever going to be able to begin to estimate organ doses of the bone marrow with an SSDE. Important point. SSDE cannot, do not, under any circumstance, substitute it for CTDIvol when you use the standard K factors to estimate the effective dose from a CT exam. All those K factors were established and published based upon either the CTDIvol from the 16 centimeter phantom or the 32 centimeter CTDI phantom. And so we cannot substitute SSDE for that. Please also note that SSDE is the dose to the tissue that's irradiated. It's not an effective dose. We're actually talking about dose to the soft tissue. It's not going to resemble at all the dose to bone in the scan volume because, of course, the dose to the bone is going to be elevated relative to the soft tissue. We need to start calculating SSDEs. I've given you some examples of how they're more accurate of estimates of patient dose in CTDIvol. I'd like to see SSDEs as opposed to CTDIvols recorded in the patient's medical record. It's a better representation of the patient dose. DRLs in this country, the ACR for instance, are based on CTDIvol values. They're also based in Europe on CTDIvol values, but they could be based in the future on SSDE values. And SSDE values can be used to lead to department dose standards in the future. And I'm going to show you how SSDE values can be used as a tool to manage patient doses in the pediatric clinic. And there's work ongoing to encourage the CT manufacturers to display SSDE values on their future scanners. So let's look at an example in the time that we have left of how we could manage pediatric CT patient doses. Well, again, if you're a consulting physicist or you're a staff physicist, you're going into the facility and you should be making CTDIvol measurements on an annual basis with the 32 and 16 centimeter phantom. You need to take those results and compare them with respect to the ACR reference values and determine what we're trying to determine here is the facility using reasonable doses for their adults? You know, are they high, are they moderate, are they low? I think we can make the assumption that if a given facility is using relatively high doses on their adults, they have an intolerance for noise, and they're probably going to want to use relatively high doses for pediatrics also. Or if they're using low doses for adults, they probably will be able to tolerate lower doses for children. But again, these reference values shown allow us to make a judgment on how the facility is doing with respect to its adult patients. Well, now that you know that the facility is doing a reasonable job with its adults, you need to establish an appropriate pediatric dose. You can do that simply by reducing the mass. You can do that if you calculate the SSDE, because your SSDE for any pediatric patient should be less than or equal to the adult SSDE in the department. It's a pretty simple rule to give the adult facility that does children occasionally. We can get the size of the patient from the projection scan prior to doing the axial scanning. So the operator has the opportunity to calculate the SSDE from the technique parameters that they've chosen prior to doing the scan. And if the SSDE is greater than their adult SSDE in the department, they know they need to do something. Now, it turns out that if you look at the data in TG204 for a 10 centimeter AP child, you're going to use about 40% of the original mass for the child that you'd use for the adult, provided that you make sure that the SSDE for the child is slightly less than that of the adult. Before you had SSDEs, what you could do is you could use the Imagenologia website model for mass reduction. And if you look at that data for the 10 centimeter AP dimension, you would have reduced the MAS value to 45% of its original value. Again, very similar to what the SSDE recommends. And again, the Imagenologia protocols are designed to reduce the pediatric patient dose to values just slightly less than the adult. And again, if we look at this, somewhere here between the 9 and 12 centimeter patient, we've got a mass reduction factor of about 0.43 relative to the adult. Well, as I said, the dose reduction on the IG website is conservatively high today, and there's a lot of facilities that are doing better than that. If you have a dedicated pediatric department, this is what they might be doing. Their newborns might be imaged at doses that are 60% of the adult SSDE, and that number is going to grow as you move towards an adult-sized patient. That's a more aggressive protocol. That reduces the dose to the children more. That may be tolerated in a pediatric facility. It's less likely that's going to be tolerated in an adult facility because the radiologists don't have as much comfort level at looking at the pediatric images as they do the adult images. Well, then you ask the question, well, that's all great, Keith, but shouldn't we be reducing the KVP as we image children? And you're right, we should be reducing the KVP. What we've done to this point is grab the low-hanging fruit, help the adult institution that does children occasionally get their doses so that they are reasonable. If their pediatric doses are equal to their adult doses, that's a reasonable reduction. They can do better than that, but that's reasonable. If you really want to work at this and you have the time, how do we reduce the high voltage appropriately in children? Well, the simplest method is to either use the SSDE or use the protocols on the Imagenologia website and come up with your reduced MAS technique. You dial that reduced MAS technique into the CT scanner and note the change in the displayed CTDIvol. If you, for instance, reduce the MAS by 50%, I'd expect the CTDIvol to go down by 50%. Then what I do is I reduce the KVP to 100 KVP or 80 KVP, whatever I might choose, relative to 120. And I turn the MAS up until the CTDIvol at 80 kV is equal to what the CTDIvol was at 120 kV. The scanner tells me that. As I adjust the technique factors on the scanner, it's going to tell me how the CTDIvol is changing. And so notice that what I've done is I've reduced my high voltage. This is the case of let's reduce high voltage and keep the same dose. So I'm going to make my CTDIvol at 80 kV equal to the CTDIvol at 120 kV. What have I done? I've increased the contrast in the image by reducing the KVP. And I've maintained the original dose that I said was my reduced dose technique from either matching the SSDE to the adult SSDE or by looking at the protocol on the Imagenologia website. Now that's the simple case of reducing the KVP. I probably can do more. I can reduce the KVP, and I probably can also reduce the dose. What do I do now? Well, again, I dial up my reduced MAS technique. I note the displayed CTDIvol at 120. And then what I do is I measure the increase in contrast in the image as my KVP is lowered. And of course, how do I do that? Well, the ACR accreditation Phantom's got an insert, a low contrast insert in it, and you can measure contrast in that insert, and you can measure the contrast that is being generated by the scanner at 120 kV, and you can measure what it's generating at 80 kVp. If you're doing that measurement, again, you probably want to keep the field of view picked clinically so that you've got the correct bow tie filter that you're working with, because that's going to affect the change in contrast as a function of the change in technique. So now I've decreased my KVP, and I've quantified and measured the increase in contrast. Well, I've also noted, now all I've done is reduced my KVP. I've left my mass the same. So my dose is artificially low. Okay? But I can compare my CTDIvol again at 120 versus my CTDIvol at 80 and get the ratio of the two doses. And from that ratio, I can estimate how much the noise increases in the image from the reduction in dose. So let's assume, for instance, that my contrast, by reducing the KV, increased 40%. And because I haven't done anything yet with my MAS to compensate for the reduced KVP, let's just assume my noise went up 60%. Well, obviously that's going to reduce the contrast to noise ratio in my image, and I don't want to do that, so I'll increase the mass at 80 kV until my contrast to noise ratio at 80 kV is equal to my contrast to noise ratio at 120 kV. So now what I've done is I've provided essentially the same image quality at a reduced dose. The contrast is elevated in the image relative to what I started with because I'm at a lower KV. But because I've reduced the dose, my noise is also elevated in the image so that my contrast to noise ratio is unchanged. So I can use either one of those techniques to start to get a handle on what I need to do with my pediatric exams. Now, in the dedicated pediatric hospitals, they're moving towards exam-specific protocols. It's a lot of work, especially if you have different scanners in your department. Again, if you're the consultant going in to the adult hospital that does pediatrics occasionally, more than likely that adult hospital is not going to be doing the more complex pediatric exams. They're going to be doing abdomens and pelvises and maybe some chests. And grab the low-hanging fruit. Find the techniques that they're using on kids the most and start to do these kinds of protocols. Okay, as a consultant, you obviously don't have a lot of time to invest in these kinds of activities for most of your clients because they're not willing to pay for the service. So grab the low-hanging fruit. Try to make sure that the adult institutions doing kids occasionally are delivering doses equal to or less than the doses that they're delivering to their adults. So in summary, adult hospitals image about 80% of all pediatric patients, and as a result of that, they should have specific protocols for kids. I can use the adult protocol to calculate the adult SSDE. I can settle on an SSD for pediatric patients that's prior to the scan that's equal to or less than the adult SSDE. And I can, if I want to get really involved, I can change the KV in addition to the MAS. If I don't have the time to do that, I can simply just change the MAS to make sure that the doses that the children are receiving are reasonable. Do you have any questions? What put the microphone at the front of the room.
Thanks for the talk. I'm wondering if you could talk a little bit about how well auto-MA or CareDose works in these situations, because I think as a consultant, that's where I would tend to push our clients, for abdomens and things like that, and that's what they're using already for adults.
Right.
So I wonder if you could discuss that a little bit.
Okay, good question. CareDose, in my experience, works reasonably well for children. Out of the box, installed by Siemens. It does work reasonably well. What doesn't work reasonably well for children is the noise index that you find on a GE CT scanner. The noise index value changes as a function of patient size. And to provide appropriate image quality at the least dose, the noise index for the smaller children needs to increase. So I've got that backwards. The noise index is the inverse of the actual noise. So you're running smaller noise indexes on children because you need images that have better contrast to noise ratio in them for children than you do for adults. So the CareDose is relatively automatic for children, and it works quite well. GE's noise index programs, if you have a noise index of 15, and that works great for adults, pediatric images collected at a noise index of 15 probably will not be deemed acceptable by the radiologists in that facility. And I haven't had that much experience with Toshiba and Philips, but my understanding is that one of them does automatic exposure control kind of according to the model of GE, and the other one according to the model of Siemens. So, but as far as GE and Siemens are concerned, Siemens CareDose works quite well. Other questions? Thanks for coming, and safe journeys on your travels home.